Hi everyone, I'm Dr. Pillai here. I'm one of the endocrinologists currently working in the UK. So today we are going to talk about hypothyroidism. As you know, this is a very common condition which causes an underactivity of the thyroid. So in this video, we are going to discuss the therapeutic options, the investigations, and the common causes of hypothyroidism. So let's get started. Okay, so before we begin, let's have a look at the normal anatomy of the thyroid gland. As you can see, this is a butterfly-shaped gland in front of the neck. It has got two lobes and an isthmus which connects it together. So this is where all the thyroid hormones are produced. And we'll go to the next slide to see how it is synthesized in the body. So this is thyroid has got this particular cells called thyroid follicular cells. This is where the thyroid gland actually produces its hormone. So if you take it from there, there is a sodium iodine symporter which transfers sodium and iodine both into the cells, which goes into the colloid inside the thyroid follicles, get oxidized. At the same time, these cells also produce thyroglobulin, and these two combine together by conjugation to form, first iodination to form iodized thyroglobulin, and then they conjugate to form active molecule thyroxine T3, thyroxine T4, and triiodothyronine T3, which gets excreted into the circulation. So this is another slide which shows overall control of the thyroid hormone production in the body. So we can see that there is hypothalamus, which produces a thyrotropin releasing hormone TRH, which then goes to the anterior pituitary to induce the production of thyroid stimulating hormone TSH, which in turn stimulates the thyroid gland to produce T4 and T3, which we have seen in the previous slides. So like in any other endocrine system, there is always a positive feedback and a negative feedback working in tandem to maintain homeostasis. So when you need a lot of thyroxine hormone in the body, the TSH levels go up, inducing the production of T4, and on the reverse, we have too much thyroxine T4 in the body. It induces a negative feedback, thereby reducing the production of TSH. So in hypothyroidism, as you would expect, your TSH will be high because you don't have enough thyroxine in your body, so the T4 levels are low. So to compensate that, TSH levels will go up. So that is usually the typical picture. Your TSH is going up, T4 going down. That is invariably hypothyroidism. Okay, so now we have seen the anatomy, the normal physiology of thyroid hormones and how they work in tandem. Let's look at some of the common causes of hypothyroidism. So you can see that depending on the world where you live, the cause of hypothyroidism varies quite a bit. In iodine deficient countries, iodine deficiency is one of the commonest causes of hypothyroidism. But in other countries, probably autoimmune disease like Hashimoto's thyroiditis, previous surgery for thyroid, either cancer or for any other reasons, like an overactive thyroid, like hypothyroidism. We can also become hypothyroid with treatment for hyperthyroidism. You give carbimazole for a few months, and then you can become hypothyroid. And there are other causes like congenital causes, which can cause congenital hypothyroidism. This is very important to detect. early in the childhood or infancy, so that we can prevent severe neurological developmental problems. And also pituitary, so as you can see, the TSH is produced by the pituitary, so for some reason hypopituitarism can also develop hypothyroidism. This is called central hypothyroidism. One important thing to remember here is your TSH levels won't be going up here because there is no pituitary to produce TSH. So this is one of the conditions where you can get a lower free T4 with a relatively normal or low TSH. So this is inappropriately normal or low. So you have to think about central causes and look for pituitary pathologies there. So the symptoms of hypothyroidism are quite varied. So you can get initially with no symptoms, then depending on the level of thyroid, people can get different symptoms, including fatigue, constipation, shortness of breath, hair loss, dry skin, carpal tunnel, high cholesterol, and in ladies with menstrual irregularities. So you can get quite a wide variety of symptoms with hypothyroidism. So once you have a patient with symptoms suggestive of hypothyroidism, and you do next some investigations like biochemistry to look for the actual thyroid function. So you do baseline pattern like a TSH, free T4, a free T3 if needed. It's not always required. You'd be able to make the diagnosis with a free T4 and TSH alone, a typical pattern being TSH high, a free T4 low. So it's pretty much hypothyroidism. And you also might need to do a TPO, thyroid peroxidase antibody, because if you cannot find an obvious cause like iron deficiency or previous surgery, it's worth looking into this TPO antibody, Hashimoto's thyroiditis, so chronic lymphocytic thyroiditis causing the hypothyroidism. So that is something to keep in mind. To make the diagnosis, probably this is going to be a lifelong condition. There is no other role for TPO antibodies after once you make the diagnosis in the management of hypothyroidism. Except in pregnancies, this might be of help because there is some evidence suggests this is related to pregnancy loss, but still your management will be to optimize the thyroid function by looking at the TSH and free T4. So how do you treat it? So you treat it by giving them levothyroxine. So the usual dose is 1.6 micrograms per kilograms. So in elderly, you might want to start at a lower dose because of the thyroxine's metabolic profile. It can cause cardiac problems, precipitate heart failure, or cause induced arrhythmias, common arrhythmias like atrial fibrillation. So might need to start at a lower dose in elderly, but in relatively young and well patient, you can straight away start at a higher dose. And also you might need to remember the fact that T4, levothyroxine, has got strong interaction with food. So it's always good to tell the patient to take this first thing in the morning, empty stomach, and avoid any other medication food for the next half an hour to an hour for maximizing the absorption. You'll be surprised to see how many patients don't know this and take them with other medication and after food and come back with hypothyroidism not correcting. So first to look at the way they are taking the medication, making sure they get it right. And T3 and Armour Thyroid, these are other forms of treatment, but most of the places in the world it is not accepted as a standard treatment, but people are taking these due to many reasons. Some people feel thyroxine on its own or normalize their symptoms, so T3 is indicated in some of the situations, but it needs careful consideration because of possible adverse events due to its treatment, and you should probably ask somebody who's more experienced in managing somebody on T3, because normal thyroid functions can, including the free T4 and free T3, can get affected with T3 treatment. And Armour Thyroid, I usually don't recommend this at all because of the wide variety of preparation you get, and actually you don't know what exactly in it, so it's worth avoiding those kind of treatment. So once you're on this treatment, monitoring, you really need to monitor with TSH. As you keep biochemical parameters, you adjust the dose of the treatment according to the TSH and try to maintain the TSH in the normal range. Overcorrecting with the levothyroxine, keeping the TSH suppressed, might also cause problems like osteoporosis, atrial fibrillation. So these are the things you want to avoid. So I would suggest keeping the TSH in the mid-normal range or in the normal range if at all possible, and try to look for other causes for the patients. If still their TSH in the normal range, it gives them some time for the body to get this to adapt and see if that helps. If not, look for other causes if the TSH is normal and the patient has got ongoing symptoms. So before we finish our talk, we will briefly touch upon something called Myxoedema coma. This is a very rare condition which is kind of severe hypothyroidism and affecting multi-organ dysfunction. So as the name suggests, the patient can come in with some reduced mental status and hypothermia. So if you suspect this, you might need to do the baseline test and take cortisol as well. These patients are usually very sick. You might need to call your critical care colleagues to manage them in an ICU, ITU setup with or a high dependency unit. The treatment usually consists of fluids, antibiotics usually needed because it might have precipitated by an acute illness, and until hypercortisolism is ruled out, you might need to give them hydrocortisone as well. So these patients are quite sick or probably on ventilators or in a state not to take medications. So you might need to consider levothyroxine treatment as intravenous. So give a 200 to 400 microgram stat, then continue with the 50 to 100 micrograms once a day intravenously until they are well enough to take the tablets through NG feed or oral route. Might need to consider T3 as well, triiodothyronine as well here. You might need to give a 5 to 20 micrograms stat and then 2.5 to 10 micrograms 3 times a day as intravenous injection. So you might need to look for the causes of the Myxoedema coma, like infection or ulcers or a cardiac event. So we need to look into those as well. So this is a very rare condition but quite serious, so worth keeping in mind. So thanks for listening to this. I would appreciate if you have any questions, just put it on the comment, and I will come back with another video very soon. Thanks. Bye now.